So during this presentation, we will discuss about how diabetic cataracts form, how can we recognize the early cataract changes, how can we identify common complications, and when and why should we refer those patients early. So diabetes mellitus, as you all know, is the most common cause of metabolic cataracts in dogs. And while diabetes can affect other structures of the eye, like the cornea or the retina, cataract formation is one of the most prevalent and important complications of this disease. Diabetic cataracts matter. They progress in a large proportion of dogs. A published study by BM in 1999 showed that the majority of dogs developed cataracts 5 to 6 months from the time of diabetes diagnosis, while 80% of dogs developed cataracts 16 months from the time of diagnosis. That's a large percentage of dogs with cataracts. Let's have a quick look at the anatomy, the basic anatomy of the lens. So we have in the front the anterior lens capsule, and behind it we have the anterior epithelial lens cells. Posteriorly, we have the posterior lens capsules, and behind the anterior and in front of the posterior lens capsule, we have the cortex, the anterior cortex, and posterior cortex, respectively. And in the middle, we have the lens nucleus, which is divided in 3 zones: the adult nucleus, the fetal, and the embryonal nucleus in the center. And this is a slit lamp photograph. It's a sagittal view, so you're looking at the lens from the side, and you can see that the first beam, the slit beam of the slit lamp is hitting the cornea. Then we have the anterior chamber here, and then that's your lens. That's your anterior lens capsule, your anterior cortex, your lens nucleus in the center, your posterior cortex, and your posterior capsule. And this is an electron scan microscopy photo where the iris and the cornea have been removed, and you can see the lens here. It's attached to multiple lens zonules that are attached to the ciliary processes. So briefly, I would like to mention that the lens is an avascular structure, so it provides transparency for the eye. It's a major refractive organ. It contributes to accommodation, which is the eye's ability to focus images on the retina. It blocks UV wavelengths and protects the retina, and it's a barrier between the anterior and the posterior segment of the eye. In order for you to understand how the diabetic cataracts form, you need to remember that the lens gets its glucose via 4 different mechanisms. The most common mechanism is the anaerobic glycolysis, which gives us lactic acid and ATP. We have the Krebs cycle, we have the pentose shunt, and we have the sorbitol pathway as well. In diabetic patients, we have increased glucose in the lens cells. So the lens can no longer metabolize all this glucose via only the anaerobic glycolysis pathway. So when we have increased glucose in the lens, the enzyme aldose reductase, which is in a lot of quantity in dogs, becomes overactive, and it starts metabolizing glucose via the sorbitol pathway, so it leads to sorbitol formation. Sorbitol is osmotically active, so it leads to osmosis. Osmosis means that there is water going in the lens from outside the lens. So suddenly your lens is getting a lot of water influx, it becomes cataractous, the lens fibers start swelling, and sometimes the membrane can even rupture due to the swelling. Early lens changes are incipient cataracts, and particularly equatorial vacuoles. The equatorial vacuoles, you can see them in those photos here. Basically, they are very swollen lens fibers due to water accumulation, and these start to form in the equator of the lens, and as the cataract progresses, the cataractous lens fibers start moving more centrally as well. The progression from an incipient to an immature to a mature cataract, this is an immature cataract on the right, and this is a mature cataract on the left, is actually quite quick with diabetic cataracts. It can happen within days or weeks. And when the cataract becomes mature, as you can see on the bottom left, many times we see visible suture lines, anterior suture lines, which is the Y structure. You can see here, these are the water clefts, as we call them. And even if your patient is well controlled with diabetes, that will not stop the progression of the cataracts, unfortunately. What complications can we encounter sometimes secondary to cataract formation? The most important is phacolytic or lens-induced uveitis. Uveitis means inflammation inside the eye. And phacolytic uveitis forms when proteins from the cataractus lens start leaking through the capsule to the rest of the eye. As we said before, the capsule is quite stretched, quite enlarged, so the pores of the capsule become enlarged, and this is how the proteins find the opportunity to leak out of the lens. Many patients with early or late immature cataracts or newly mature cataracts have low-grade uveitis, and that can easily be missed. So clinical signs that we are looking out for these patients are conjunctival hyperemia, aqueous flare, miosis, discomfort, and in more chronically inflamed eyes, episcleral congestion, edema, synechiae, iris hyperpigmentation. My advice to you is that in any diabetic cataract patient that you see, start topical treatment with topical anti-inflammatory drops or topical steroid drops, like Yelox, Acular, Pret Forte, or Maxidex, twice daily at least. This way you will keep the lens-induced uveitis as low as possible. I've just included this paper in case you're wondering, is it safe for me to use topical steroids in a diabetic patient? And that paper compared two different groups of dogs. One group was getting prednisolone acetate, that's Pret Forte, 4 times daily, and the other group was getting diclofenac 4 times daily, which is a non-steroidal anti-inflammatory, and there was no significant difference in terms of fructosamine serum levels in either of these groups, so it's safe for you to use topical steroids. These photos here show you phacolytic uveitis. So the photo on the top right, you can see the corneal edema, you can see the episcleral hyperemia, you can see the corneal vascularization as well, and the iris hyperpigmentation. In this photo here, again, your slit beam hits the eye like that, so you can appreciate that there is some light on the cornea, and then there is actually quite marked uveitis here. You can see the Tyndall effect, the quite marked aqueous flare in the anterior chamber. And on the photo on the bottom right, you can see quite marked keratic precipitates, again some posterior synechiae and iris hyperpigmentation. Other complications that can form post-cataract formation are phacoclastic uveitis, that is a slightly different type of uveitis. So with the phacolytic uveitis that we discussed before, we have leakage of proteins through the capsule. In the phacoclastic uveitis, we actually have rupture of the capsule. So the lenticular material has the opportunity to escape from the lens in the eye. Glaucoma is a very common complication in dogs with cataracts. Lens laxation is another complication, and also retinal detachment. These photos are from this paper that I have included here from you. This is a really nice paper by David Wilkie, and it shows that actually, I think they studied, 22 or 24 dogs, I can't remember now, and the majority of them had pre-existing tears of the lens capsules even before referral. And you can see the top right photo, you can see really marked, really chronic phacoclastic uveitis. You can see the marked corneal vascularization, the edema, the keratic precipitates. This eye is beyond salvation. No matter who sees this eye, they cannot operate, they cannot do cataract surgery on this eye. So this eye was eventually nucleated. And this eye on the bottom right is, I don't know if you can appreciate, there is actually a quite large tear here on the anterior lens capsule. It's like a flap, and the cataract has found the opportunity to escape and is actually in the anterior chamber. And here, this is during phacoemulsification surgery. You can see that the surgeon is pointing out a quite large stair up there with their instrument that was pre-existing before the surgery. So when to refer? Refer those patients early, I would advise you, when the cataracts are immature, when the diabetes is newly diagnosed and you're stabilizing the diabetes, and when there are no signs of uveitis or glaucoma. But refer them urgently when you can see that there is discomfort of these patients, there is hyperemia of the conjunctiva, you can actually see signs of uveitis like aqueous flare, synechiae, keratic precipitates, or hypopyon. When you have glaucoma, the pressure is above 25, and when the cataract is mature and your patient has gone blind quite suddenly. It's very important that you communicate these things with the carers quite early in the disease process. Even when the diabetes is diagnosed and even if there is no cataract, inform them that it's a possibility this might happen. Inform them that the option of referral and the option of cataract surgery is there, it exists, and it's something that we do very frequently. And advise them that early referral is preferable so that we can assess the patient, and then we can discuss with the carers about, details about the surgery itself, the complications, the risks, the prerequisites, and all of these things. I appreciate that sometimes many clients do not wish or cannot be referred for whatever reason. And then if that happens, if referral is not an option for your client, then, as I said before, I strongly recommend that you start some topical anti-inflammatories and maintain them lifelong so that you reduce any lens-induced uveitis and you keep that controlled. Be careful with lifelong topical steroids because diabetic dogs can also develop dry eye disease. And so if you're giving them lifelong steroids, you might, and they end up developing any ulcers, you might have any problems there. Inform your clients of all the possible future secondary complications that cataracts can lead to, like lens luxation, uveitis, glaucoma, retinal detachment, all of these things we've discussed. Reassure them that cataract surgery is optional. This is something I always say to our clients. It's not a mandatory surgery, it's not a life or death situation, so it's not a wrong thing if they do not wish to go ahead with that. And reassure them that blind dogs can live good quality lives. You can also provide them with resources about that. And if your clients are against the idea of surgery for cataracts, but they are open to the idea of seeing an ophthalmologist, I still think these cases are worth being monitored by an ophthalmologist, so we can monitor the progress of the cataract, we can monitor for additional complications, and catch them as early as possible. Even if surgery is not an option, it's still worth us seeing those eyes. I've just included these two papers just to show you that medical management of cataracts is an acceptable option. And according to these two papers, the group of dogs that had phacoemulsification did not have any significantly different or additional, if you like, risk factors for complications versus the group of dogs that did not have cataract surgery due to their carer's decision. The patients here that actually had increased complications were those patients where the vets decided not to operate it on them. Having said that, if you read those papers, you will see that the majority of the diabetic dogs actually belonged to the phacoemulsification group rather than the medically managed group. So what I want you to take home with you today is that diabetic cataracts progress fast. Early detection, early referral is important if your clients want to save their pet's vision. Early treatment with topical anti-inflammatory drops prevents lens-induced uveitis, so it's something I would encourage you to do when you diagnose these cataracts. And never ignore a red or a painful diabetic eye. It means that either you're not controlling the inflammation well enough, or the pressure is starting to increase, or the lens becomes unstable. these are some of my references for your information. Thank you for your attention.